My name is Kayley Mundis, and I am currently enrolled at Bethel University in Senior Care Regulatory Management, taught by Paul Floyd. And I will be talking today about polypharmacy as it relates to elderly living. The definition of polypharmacy, essentially poly means many, several, or much, while pharmacy is the practice or profession of preparing, preserving, and dispensing medical drugs. There's no one defined aspect of polypharmacy, but it is noted as the simultaneous use of multiple drugs to treat a single condition. At this time, there's no agreed upon number of medications, for example, 5 or 7, that specifically define polypharmacy. However, it is those medications not indicated as effective or that are of duplication, as noted by Hall. It is known that the geriatric population is increasing, and today 1 in 9 persons are of the elderly population. It is found that by 2050, that number will be 1 in 5. So of course, that does constitute a significant challenge for healthcare authorities worldwide. Along with advancing age is that encompassment of chronic disease that's already common across that population, including disease such as hypertension, diabetes mellitus, arthritis, chronic heart disease, or renal disease, as noted by Dogley and Sharma. And that does result in elderly persons having that need to take multiple medications daily. Polypharmacy accumulation in geriatrics. So on the previous slide, I notated those common chronic conditions already prominent within the senior population. Think of those seniors who have maybe 2 or even 3 of those chronic conditions and how much or how many medications they are prescribed day to day. So essentially, rising acuity levels amongst the senior population is directly affecting, of course, seniors. Medication increases as well as that polypharmacy aspect, and essentially directly affecting long-term care communities, especially those assisted living communities in which the manpower is not quite as high as perhaps a skilled facility. Of course, this means more chronic conditions and more complex regimens may not allow those who are cognitively impaired to self-manage their medications any longer, falling back onto staffing at assisted living and skilled facilities and making sure their patients are adhering to those regimens appropriately. Seniors on average are taking 12 to 14 medications daily, and that number is more than ever before, as notated by Hall. Along with this, there is some loss in communication that attributes to the accumulation in geriatric polypharmacy as well. For example, a patient going from home to the hospital to rehab, maybe then back home, and then being admitted to a long-term care facility such as assisted living or skilled nursing. If that communication is not properly followed through upon, there could be some stuff or some regimen slipping through the cracks. At the same time, primary care physician management is very important, and if those physicians are not having periodic visits, keeping up to date with developments, or educating their patients on their regimens as to why these medications are necessary, there could be some concern in there as well. Pharmacies play a large role in long-term care communities, primarily helping with prescription processing, creating that medication record, and clarifying med orders, dispensing and delivering medications, properly labeling, packaging meds, and delivering in a timely manner. Medication administration and management, they help supply med carts, perform quality assurance checks and consultative services, and then they do help accept returns and assist in proper disposal of substances. A lot of long-term care communities are veering on the pathway towards using one single preferred pharmacy. Again, to delve in a little bit deeper on that reliance on pharmacies within long-term care communities, as mentioned, seniors are taking on average 12 to 14 medications per day. Non-regulated communities may have some unlicensed personnel on site as well that need help with adherence and education aspects. And then facilities, especially assisted living facilities, are not always staffed appropriately. So the reliance on pharmacies is kind of that extension to an on-site team, so to speak. That dependence includes clinical support, as mentioned, adherence, drug dispensing and distribution, on-site training, on-site consulting, and cart auditing. And then primary pharmacy providers, as I mentioned, are pretty popular now in long-term care communities. It simply allows for that single point of contact, consistency, reliability, and quality, improved efficiency, streamlined maintenance, and a lot of those pharmacies are keeping up with those long-term care regulations and policies needed, as notated by the Lewin Group. Symptoms of polypharmacy. Sometimes it is hard to directly identify symptoms related to polypharmacy, as many of them are normal aging signs, such as tiredness and sleepiness, decreased alertness, constipation and diarrhea or incontinence, loss of appetite, confusion, falls, weakness, and tremors, as well as lack of interest or depression. As I mentioned, it is hard to exactly pinpoint relation to polypharmacy, as many of these are so common in the elderly population already. Consequences of polypharmacy in elderly residents. Of course, primarily increased healthcare costs are noticeable for both the patient and healthcare system. There are amplified outpatient visits and hospital stays. Higher prescription drug expenditures, of course, for patients. Adverse drug effects, or ADE. Approximately 10% of emergency room visits are due to ADE, and this is noted to be twice as high in nursing homes. Medication non-adherence. This is associated with those complicated medication regimens, and elderly persons are not always able to plan and follow routines appropriately. There's been noted a decline in functional status, which does lead to patient falls. And that decline is more noticeable as the medication numbers rise, as well as cognitive impairment. And this has been found to increase as number of patient medications increase. And in a study led by Mayer, Hanlon, and Hajar, it was found that 22% of patients taking 5 or less medications have direct noticeable cognitive impairment. Those who take 6 to 9 medications increases that percentage to about 33%. And then it is found that 54% of those who take 10 plus meds have a direct relation to cognitive impairment as well. Some acts that may help reduce polypharmacy include, the importance of linking each prescribed medication to a disease state or diagnosis, or pinpointing a reasoning behind each medication. Is there more than one medication being used for a single condition? Communicating with patients to keep accurate lists of medications, and discussing a reasoning behind each medication and why it is prescribed. Advising patients with proper instruction and reiterating adherence. Also advising patients not to stop taking a medication before consulting their prescriber. Educate patients on organization and linking their daily scheduling. For example, take a medication after brushing your teeth, or while you're eating lunch or after dinner. Specified primary care visits for medication review only. In this aspect, asking patients about their adherence to their regimen and not being afraid to really delve into that question and making sure that they are following their regimen appropriately and documenting as such. In long-term care communities, it is highly beneficial to maintain an appropriate system for med delivery. Also, observing patient reactions or variations upon a new prescription. Essentially, you know your residents better than perhaps a primary care physician would, or a hospitalist, for example. Don't be afraid to ask the pharmacists about variations and meds that are seemingly used for the same reasons.